So without further ado, I'd like to introduce Rick Rawson.
Thanks very much, Larry. Next slide, please. I did a lot of work during, well, about 40 years at UCLA on stimulants, first cocaine, then methamphetamine, and that's been a good deal of my career. As Dr. Taylor pointed out, starting in about 2016, there started to be increased use of stimulants and stimulants being involved with overdoses. And I started getting lots of emails for people asking me, what should we do about this? West Virginia being one of the first. And I said, well, contingency management has the best data. And over a number of months and years with West Virginia and other states, the answer was, well, we can't really do contingency management. There's no way to do it. There were all kinds of regulatory problems. We worked on those regulatory problems, and then we had to work on the financing problems. And we now have some answers for how people can actually do contingency management. These were, again, some of the other challenges. There was the skepticism about the idea of this intervention of providing gift cards. I had a doctor say to me, I didn't go to medical school to hand out Walmart gift cards. It was not seen as a legitimate public health intervention. With the data that we have, makes it hard to argue, however, that this is not a significant public health. As Tom mentioned, we now have good data on the effect on mortality. There will be an article coming out soon on cost effectiveness showing it has a huge cost benefit. So we've got a lot of data to convince people that this is a useful thing to do. As I mentioned, there were regulatory obstacles of those groups that started to do contingency management. There were a lot of random things going on and being called contingency management. People who come into the group get a candy bar. People get a gold tag if they come in. And there were a lot of use of incentives and positive reinforcement, all of which is great, but it's not contingency management. Contingency management, to do a contingency management program, according to the research, there's some certain guidelines that need to be followed. There were no places to do training. If somebody wanted to do contingency management, how do you get trained to do it? That wasn't available. But by far the biggest issue I've run into as I've gone around to different states and different groups trying to help them with contingency management is, how do we pay for it? We want to do it. We're convinced it's a good thing to do. We have a huge meth problem. How do we go about financing this? And so that's what I'm going to talk about primarily. Next slide, please. Currently, contingency management is not a service that can routinely be billed to Medicaid or to the federal block grant. However, it can be financed via SAMHSA TOR and SOR grants up to a maximum of $750 per patient. Now, this is a change. As in January, there had been a limit of $75 per patient, which is subtherapeutic. It's like giving people 2 milligrams of buprenorphine. It's not an effective contingency management parameter. But now SAMHSA changed that, and you can use SOR and TOR grants. However, states have to apply to use this money, and there's some time involved in getting that put together. But that is certainly one mechanism for financing. When people talk about financing, there's the question of, well, how much money do we need to do this? And what should our protocol deliver to patients? And there's some variation. One of Sheila's colleagues, Carla Rash and colleagues, just published a great article outlining what the parameters are for effective amounts that are used. And they're in this ballpark of $500 to $1,200 for anywhere from 12 to 24 weeks. But they're more than candy bars. You have to provide a significant amount of money to make contingency management work. In California, when we were working on the development of that program, the 6-month period, the 24-week period was what we chose for duration, and $599 was chosen as the maximum amount, not because of evidence, but because there was some concern that this might require if you go above $600, the patients have to get a 1099 form. There's a whole debate about that right now, but that was the basis of California using the 599. Next slide, please. This is the SAMHSA advisory. This is what raised the $75 to $750. And this gives you information about how the money can be acquired through the SOR and TOR grant programs. And that's certainly an adequate amount to do a robust contingency management program. Next slide, please. These are some of the strategies we've seen used. The SOR, TOR grants actually have not been used yet to do contingency management, but they are available sources. We've seen in some states they've used state money. The state of Montana used state money initially. They now have a waiver. In Maine, they're using some private grant funds. California, Washington, Montana now are using the 1115 waiver process to use their Medicaid funds. Some places have used the foundation money. Some of the tribes have used casino funds to fund contingency management. But in the last several years, the number one source of use of money for contingency management has been the opioid settlement funds. As you heard from Sheila, that's how Connecticut is funding contingency management. Next slide, please. The opioid settlement funds are every state got money from the companies that facilitated the opioid overdose crisis with prescription opioids during the first decade of this century. And states have a great deal of flexibility in what they do with this money. Many places have not realized that they could apply for this money to do contingency management. One of the complicating factors in getting this funding is that every state does it differently. Within some states, it's by county, some states it's by city. Some places, individual providers can apply for it. So the first step is figuring out how to access the money. And what is the application process? How do you go about applying for this? When is the deadline? When can you submit for this money? And so on. Next slide. These are some of the websites that have this information state by state, how you go about doing it. And these are resources if you want to look into getting opioid settlement money for contingency management. Next slide. The thing that's important that most of the programs I've worked with and states I've worked with is they don't know how to pitch it. You have to write a pitch. You have to give the committee a rationale for why they should be spending their money on reducing stimulant use with contingency management. And so this is some ideas about what you go into a pitch. I actually have a blank one that a sample, if people are interested in, that you can use as a model for a pitch for doing this. But it does take initiative from providers and states to go to the committee, give them a proposal for what you want to do and how much money you need. Next slide. You can skip over this one. These are some of the states that are currently doing contingency management. I sent this slide in before I knew about Connecticut's, but obviously the Department of Veterans Affairs has been doing contingency management for over 10 years. All these other states are doing it, many of them with opioid settlement funds. And there are many, every day I'm getting new inquiries about, well, how do we do this? And where can we get some funding for this? And it's great to see, for somebody who did research on contingency management, it's great to see this spread of the use of this technique. Next slide. And that's what I got for you.
Rick, thank you very much. Really, really appreciate that. As with others, Rick, I guess I had a couple of key takeaways. And number one, at the very beginning of your presentation, you said despite CM's effectiveness, less than 10% of addiction treatment programs use CM. And I just, that's a real highlight for all of us. What an opportunity to save lives. Number two is your 6 strategies for financing contingency management. So I think that's a beautiful slide, and it keeps all of us, it's something for all of us to think about. And number three, thank you very much for the website references that you put in place. Again, a massive wealth of information there, and your, I guess, your openness to field questions that people have. Um, we do have a question from the audience, and it did say, can you provide more information on the article that'll be coming out soon on cost effectiveness, so we can better keep an eye out for it. I don't know if you had any comments on that, Rick.
Well, it's an article that my colleagues at Stanford have. It's been accepted for publication, but is not yet ready for public distribution. I'll let you know, Larry, when it comes out, and if you have the list of folks that you can send it out to people so that they will know when it becomes published.
Absolutely. We'll definitely do that. And for those of you that use LinkedIn, we'll also be putting a link on that on our link, the Contingency Management Innovation LinkedIn post when that comes out.